We've got 5 minutes to go through some discussion. Any burning questions for any of the speakers?
Jean-Marc, excellent talk about the option of converting the sleeve to OAGB. My question to you, you did emphasize in your talk about using a 1.5 meter BP limb. Why is it that the Omega trial that was published in the Lancet, which was, as you know, the French multi-center trial, used a 2 meter BP limb? Why in that French study, the Omega trial, the multi-center French trial, why did they decide to use it? What was the rationale when you're recommending a 1.5?
When you do a one anastomosis as a redo surgery, whatever reason, you must measure the total limb length. I think it's very, very important take-home message.
No, very nice presentations. Just 2 aspects nobody has touched. Hiatal hernia repair. So a lot of sleeves, with or without regain, have a concomitant hiatal hernia. And if you dissect it, you will likely to find in majority of cases. So I think when the papers, some of them don't mention clearly what is the rate of hiatus hernia or was it repaired at the time of revision. And the second question is about if you're doing a revision procedure, let's say malus doctor procedure, and you find a dilated fundus, I think it's a good practice to re-sleeve that part or fundectomy or an enterectomy, whatever is dilated, as a part of the secondary procedure. So I would want comments of the experts on that.
I think it is a very important question, but already Jack Hindens said something about that. Don't add restriction and hyperabsorption at the same time in the same patient, the same day. We learned many years ago that it's going to be advisable, In terms of deciding, you can do re-sleeve, a hiatal hernia repair, if the sleeve is not very well performed. Do volumetry, scan volumetry before, deciding to reoperate the patient. But if you are there, it's not deciding, let me have a look. Is there some dilated? Give me a stapler. Don't do that. Make the decision previously. Or re-sleeve.
Grossly dilated. You dissect, you mobilize the sleeve along the greater.
But don't do re-sleeve because the sleeve was badly performed. But don't think in adding procedure. You are putting the patient on a risk. You have to make the decision before surgery. Do a CT volumetry. If the patient has more than 400 or 350, depends. Do re-sleeve, close the hiatus, and that's all. But you have to advise the patient that the first re-sleeve have failed, going to be failed again. Don't touch.
So Antonio, when you do a revision for... Okay.
Okay.
The question is, you see the dilated fundus and the hiatal hernia or not? If there is hiatal hernia, you need to dissect, repair the crura, and resect the fundus, because this is the principle.
Yeah, but I'm saying, no, Luigi, this is not what I said. This is not what I said. No. I think if the patient has a bad sleeve and a hernia, fix that, and that's all. Don't add an hypersorptive procedure, is what I said. Let me point it out.
Can you just clarify that if you're going back and converting a sleeve to a Roux-en-Y and you see a massive fundus, which clearly wasn't resected at the primary sleeve, are you advocating we leave it or resect it at the time of the bypass?
After?
At the time of the Roux-en-Y bypass.
The Roux-en-Y?
Yeah. Because not every unit does CT volumetry before all revision cases. So if when you're converting a sleeve to a Roux-en-Y and you find a large fundus, what
after Roux-en-Y?
After sleeve.
Yeah.
So sleeve to Roux-en-Y at the time of the... What would you recommend we do with that large fundus?
Of course, to remove it. Yeah, sure.
Okay, that's what I wanted to clarify.
No, but that's what you were saying. Yeah. With the Roux-en-Y.
Yeah.
Okay, sorry. I'm sorry. No. I was reinforcing the idea of not adding, that Jack said it before, not do re-sleeve and do a studies or a dural switch, or even one anastomosis gastric bypass. I'm not so sure about that. We don't have data about that, but we have data about what happens if you add restriction and hyperabsorption in the same patient. You're confused, I'm sorry.
I would like to address something that someone asked before, the limb length, because there is a study from Italy, Pavia, that they compared a retrospective study, the OHGB with 2 meters of biliopancreatic limb with another branch, another set of patients with a proportion 40% to the biliopancreatic limb, 60% to the common limb. And which one had more malnutrition issues? The fixed limb of 2 meters. And probably the other ones were longer. It means that it is obligatory to measure all the bowel, because probably those patients had shorter common limbs, and that's why they had some nutritional issues and deficiencies. So measure the bowel, please. And because of that, if we measure the bowel, we can trim the large fundus, sometimes safely. And if you do that, don't be so aggressive about biliopancreatic limbs, for instance. You can be clever and balance between the two positions. Put more restriction, don't be exaggerated in the malnutrition or hypoabsorption. If you are going for a strong hypoabsorption, don't be very aggressive in the restriction. So it's not mandatory to exclude something. We can play with the two factors.
So do you have a percentage of bowel that you leave for your biliopancreatic limb? If your total limb length is 4 meters or 8 meters?
That's it. I know very well the data from Miguel Angel Carvalho that practices the pure OHGB and is performing 60% of biliopancreatic limb always and 40% of common limb. It means that when he found a total bowel length of 4 meters, he's going to do a common limb only for 160 centimeters common limb. But that's different because that's a short bowel. It's different than a bowel of 12 meters. It works differently. It's more effective probably. So that 160 is enough for that patient. That's what he says. I'm not so courageous to do that, but I suppose that in future I'm going to hand like that, like something like 50-50 or 40-60. But it's the best strategy to deal with that issue.
Rui, I have one question about your excellent presentation as well. Can you just, I may have missed it in your talk, but could you just define what you mean as a long pouch in terms of, is there a distance? I may have missed it in your talk.
The best way to define it is you need to begin your dissection between the incisor angularis and the pylorus, below the incisor angularis. And of course, it can be as much as you can, long as much as you can. If you have a large stomach, you are going to have 20 centimeters. But if you have a short stomach of 16, 18, it's impossible.
Sure.
To have 12 or 13 or 14.
Do you worry about the risk of marginal ulcer? Is it something you've...
Sure, I'm following my patients very careful about that. I'm doing endoscopy after 1, 3, and 5 years in all the patients. And now, really, I'm having some problems with marginal ulcer, yes. But in my old one, my gastric bypass, not in those ones. Because I'm doing PPIs for 6 months for women and 1 year for men. Because the few cases I had were in men.
So if the pouch is that long,
because of alcohol is smoking.
So if the pouch is that long, do you recommend PPI for life in those patients, given that?
Not for life, for 1 year in men.
For one, okay.
6. And I go to test Helicobacter every year to treat it if it is possible. And of course, I don't allow my patients to smoke. But
last comment from Luigi, I think. We will close the session.
Your proposal, I think I would make clear that it's your proposal, and it's not fully accepted. It's not because there are not enough study to prove it, and I have a number of conceptual criticism to it, but obviously. Because the concept of Roux-en-Y for reflux and is based on the concept of the Roux-en-Y. It's not based on the pouch. And from my point of view, the idea of leaving a longer pouch is dangerous because expose the patient to the risk of having the food in the pouch going back to the esophagus due to the possible esophageal lower sphincter incompetence. So I don't understand why you should elongate the pouch. The principle, I advocate more studies in this direction because Roux-en-Y was designed more than 50 years ago. It's a long time, and it's probably the more standard conceptual operation, probably unique operation we have. So I think I wouldn't change it so easily.
That's related with the polemic about the name of the operation, because first I call it diverted OHB because that's a descriptive name. I do the OHB, as I do always, and I divert it later on. And it means that I have a large anastomosis. And with the large anastomosis, Salvatore Toloni has shown us in a brilliant paper that the pressure into the pouch is decreased. So what we are saying doesn't happen. The food will go to the bowel, not backwards, because the pressure is bigger, higher into the esophagus than into the pouch. So that's not real law. That's why OHB can effectively treat some reflux diseases. I do believe that. But for stronger ones, I put both measures. A large anastomosis to have the same treatment as OHB, and the diversion to be completely safe about criticisms for and medical legal issues in the future about cancer. Because
which is the advantage of having a longer pouch?
Like Fritz Bernd said, a longer pouch, you are going to have more restriction, and the chance of dilate the pouch in the future is less, because it's the thicker part of the gastric wall. And you don't have restriction, because in Roux-en-Y, the pouch dilates because there is a narrow anastomosis, and you create an high pressure above. And here, there is no place with high pressure.